Welcome friends and seniors. I am Dr. Divya Arora, AP Cvts in UN Meta. Today I am going to present over cardiac tumors. We'll have a brief review over the both benign and malignant cardiac tumors. As we look into the background, primary cardiac neoplasm was first described by Rialdo Colombo in 1559. And the natural tumor leading to valvular obstruction was described by Alden Ellen Burns of Edinburgh in 1809. First antemortem diagnosis of tumor was done by Barnes in 1934. Beck reported teratoma external to RV in 1936 and Moore in 1951 reported a lipoma from left ventricle. Incidence of cardiac tumor is around 0.17 to 0.19%, out of which benign comprise 70% and malignant contribute to be 30%. Here we can see the presentation of benign and malignant and further division of each benign and malignant. In benign, out of 70%, the most common tumor is myxoma, and in malignant tumors, the most common is pericardial mesothelioma. Here is pathological classification of the tumors. Pseudotumors like mural thrombi, heterotropias, and the tumor of ectopic tissue can be tumor of AV nodal origin, teratoma, ectopic thyroid. Tumor of mesenchymal tissue like hematoma of endocardial tissue, papillary fibroelastoma. Hematoma of cardiac muscle are rhabdomyoma and histiocytoid cardiomyopathy, that is Purkinje cell hematoma. Tumors and neoplasm of fat can be lipomatous hypertrophy of interatrial septum, lipoma, liposarcoma. Tumors and neoplasm of fibrous and myofibroblastic tissue are like fibroma, inflammatory pseudotumor, and sarcomas that can be malignant fibrous histiocytoma, fibrosarcoma, leiomyosarcoma. Vascular tumors and neoplasm include hemangioma, epithelioid hemangioendothelioma, angiosarcoma. Neoplasm of uncertain histogenesis includes myxoma. Neoplasm of neural tissue are granular cell tumor, schwannoma, and neurofibroma. Various others are like paraganglioma, malignant schwannoma, neurofibrosarcoma, malignant lymphoma, malignant mesothelioma, and metastatic tumors of the heart. Here is a diagrammatic picture showing the clinical presentation of the tumor. Tumors have a protein effect based upon the site of origin and location of the tumor. Like shortness of breath, angina, pain, and constitutional manifestations, example fever, are common to all the tumors. But myocardial and endocardial involvement tumor may present with sudden death or syncope, and pericardial involvement may have pleuropericardial pain. Clinical signs. Again, myocardial infarction and cardiac enlargement is common to all the tumors depending upon the location. But specific to the location, like pericardial tumor will present with pericardial effusion, pericarditis, tamponade, or constriction. And myocardial tumor may have restriction or conduction disturbances, but arrhythmias are common to pericardial and myocardial tumor. Endocardial tumor will have cavity obliteration, valve obstruction or dysfunction, and embolic phenomena. Congestive heart failure is common to myocardial and endocardial tumor. Frequency of the sign and symptoms. In around first 25% of patients may have dizziness, syncope, sudden death, hemopsis, and Raynaud's phenomena with associated AF, increased serum globulins, and clubbing. 25 to 50% of patients may present with paroxysmal nocturnal dyspnea and weight loss, along with anemia, increased ESR, tumor plop, and pulmonary emboli. 50 to 75% of patients may have fever with pulmonary hypertension, right heart failure, and mitral systolic murmur, and the rest may have shortness of breath on exertion with mitral diastolic murmur. We'll now have brief look into the benign cardiac tumors. Myxoma, it is the most common benign tumor. In adult, the incidence is around 50% and in children it is around 15%. Peak incidence is around third to sixth decade of life with more common in female. Clinical manifestation of cardiac myxoma may vary depending upon the chamber involvement. Like in left atrium, the frequency is around 75%. Systemic symptoms are common, and the tumor may embolize to brain, skin, retina, coronary arteries, kidney, limbs, and aorta. Obstructive or regurgitant lesion of mitral or pulmonary valve may be caused. Differential diagnosis, mitral valve disease, endocarditis, collagen disorder can be there. In right atrium, the involvement is around 18%. Systemic symptoms are less common. The tumor may embolize less commonly but may embolize to pulmonary or paradoxic. It may cause obstruction or regurgitant lesion of tricuspid valve. Differential diagnosis include tricuspid stenosis, Epstein anomaly, pulmonary emboli, or carcinoid syndrome. In left ventricle, the frequency is around 4%. Systemic symptoms are uncommon. It may embolize to brain. An obstructive or regurgitant lesion of aortic valve may be there. Differential diagnosis includes aortic stenosis or LV thrombus. Again, right ventricle involvement is around 4%. Systemic symptoms are less common. It may embolize through pulmonary. Obstructive or regurgitant symptom of pulmonary valve may be there. Differential includes pulmonary stenosis. This is an echocardiographic image in a patient of myxoma. The shadows under the AML in the M mode show the presence of myxoma, and in B and C image of the echo we can see a large mass prolapsing into LA and it is obstructing the mitral valve orifice. It is a polypoid pedunculated lesion with a smooth surface, may be covered with a thrombus. The size is roughly around 1 to 15 centimeter, mostly 5, and weighs approximately 70 gram. Echocardiography is the modality of choice for establishing a diagnosis, but a CT or MRI can be done in case of uncertainty as it offers higher resolution, tissue discrimination, and the extent of tumor. In radionuclide imaging, isotopically labeled erythrocytes can be seen and with area of diminished activity, but less sensitive than echo or angio. On coronary angio, we can see a vascular blush. In cardiac catheterization, there are raised intracavitary pressures. Management mainly remains complete surgical excision on CPB, and recurrent rate is very less. Here is an image showing calcified myxoma. In image A, we can see typical irregular margin and glistening surface, and in cut surface reveals focal hemorrhage. Lipoma. It is a well encapsulated tumor with mature fat cells. It can occur anywhere in the heart and at any age. Equally, both the sexes can be affected. It is a slow growing tumor. Patient usually remains asymptomatic, or it can attain a considerable size. If it is subepicardial and parietal, it may cause compression, and in case if it is subendocardial, it causes obstruction. In case of a very large tumor, resection is needed. Lipomatous hypertrophy of interatrial septum. It is non-encapsulated hypertrophy within the septum. It is more common in older obese female patients. They may present with arrhythmias or heart block. MRI is the diagnostic and it may need resection if patient is more symptomatic. Rhabdomyoma. It is more common in children. They generally present within first few days of birth. It is a type of a myocardial hematoma and is usually associated with tuberous sclerosis, in which there are hematomas in various organs, epilepsy, mental deficiency, and sebaceous edema. In generally patients having rhabdomyoma, 50% of them already have tuberous sclerosis or they may develop tuberous sclerosis. It occurs with equal frequency in both the ventricles. On appearance, it is firm gray and nodular. Mostly patient presents with heart failure or may mimic valvular or subvalvular stenosis and arrhythmias. Diagnosis is established on the basis of clinical features and echocardiographic findings. Early operation before the age of 1 year if there is no tuberous sclerosis associated, the results are good and it is indicated. This is the histological image of rhabdomyoma, which shows us large vacuolated cells with loss of glycogen, and the typical spider-like cells are present with a central nucleus and large cytoplasmic mass with strands extending to periphery. These are hallmark of rhabdomyoma. Fibroma. It is the second most common tumor. Incidence in children is around 83%. It occurs as a solitary tumor exclusively within the ventricle or its septum. Both the sexes are affected equally and it is non-capsulated, firm, nodular, grey, white and bulky tumor, leading to the obstruction of the chamber or interference with contraction and arrhythmias. Echocardiography again is diagnostic. Complete surgical excision is curative. In children with extensive fibromas, if they cannot be removed, then cardiac transplantation remains an option. This is a pathological image of fibroma. It was excised from a patient who remained tumor-free at 4-year follow-up. On cross-examination, the tumor is found to be solid and fibrous with necrosis and hemorrhage. The cut surface is bosselated, firm, and it is non-encapsulated tumor. They generally range from 3 to 10 cm in diameter and are composed of hyalinized fibrous tissue, and areas of dystrophic calcification and cystic degeneration can be seen in the central portion. Papillary fibroelastoma of the heart valves. They arise mainly from the cardiac valves or the adjacent endocardium. They resemble C anemone or frond-like projections. Both AV and semilunar valves are equally affected. If on the left side there is increased incidence of stroke, they can cause obstruction to flow or embolized. Dissection is indicated once diagnosed. On histopathology, cytomegalovirus has been recovered from the tissue, so there could be a probable connection with chronic viral endocarditis. Here we can see the gross image of papillary fibroelastoma. It is arising from the endocardial surface with multiple papillary structure, giving it like a C anemone-like appearance. On photomyography, there is typical findings with numerous papillary structures containing a core of dense connective tissue of collagen with an overlying elastic tissue layer and surrounding acid mucopolysaccharide-rich tissue, all of which is covered with the endothelium. Papillary fibroelastoma mainly occur in older adults on the aortic valve cusp and may be found anywhere else also in the heart. Operative excision is curative. Paraganglioma, they arise from the chromaffin cells of the sympathetic nervous system. Excess of catecholamines are secreted. If secreted, then mainly it is norepinephrine, but usually they are harmonically inactive and less than 2% are of cardiac origin. They occur in young and middle-aged adults equally in both sexes. 60% arise from the roof of LA, rest, interatrial septum and anterior surface of heart. On appearance, they are reddish brown, lobular, soft, and nest of chromaffin cells is present. If in case they are harmonically active, then patient may have uncontrolled hypertension. Diagnosis can be established by radionuclide scintigraphy with iodine 131. Excision on CPB is indicated, and if non-resectable, then transplantation is an option for treatment. Hemangiomas. Hemangiomas are rare. Up till date, 24 clinical cases are reported. All age are affected equally and they can occur anywhere within the heart. They are highly vascular tumor comprising of capillary or cavernous channels. Patient may have dyspnea, arrhythmias or sign of right heart failure. CT scan and MRI show high signal masses in the chamber. On coronary angiography, there can be a tumor blush and the blood supply of the tumor is identified. Total or partial resection on CPB is indicated. They rarely resolve spontaneously. Imaging modalities, they can be non-invasive or invasive. Non-invasive modality includes chest X-ray, echocardiography, CT scan and MRI plus radionuclide imaging, and invasive includes angiography. On the basis of the site of the neoplasm, we can have findings in the various modalities. In chest X-ray, if the lesion is in intracavitary, we can see calcification and mass. It may mimic mitral stenosis. And in echo and CT also we will find an intracavitary mass. And in radionuclide imaging there will be a filling defect. And again in angiography also there will be a intracavitary filling defect. If the site of neoplasm is myocardium, then on X-ray we can have cardiomegaly. On echo we can find abnormal wall motion. On CT and MRI, a myocardial mass will be seen. And in radionuclide imaging, altered myocardial uptake will be there. And in angiography, there can be compression or displacement of cardiac chamber, chamber deformity, variable myocardial thickness, and abnormal wall motion. And if the tumor is pericardial or extracardiac, on X-ray there can be cardiomegaly, on echo pericardial thickening, on CT and MRI pericardial or extracardiac mass, and in angiography we can see pericardial effusion. So this is an algorithm with establishment of the diagnosis and finally deciding the treatment of the tumor. So on the basis of history and physical examination, which may mimic many other cardiac and systemic disease, it is followed by lab investigations. They might be non-specific, suggestive of some systemic disease. Then we move with imaging, visualization of mass or distortion. If a mass is found, then tissue biopsy or aspiration cytology is planned. And after establishing the histological diagnosis of the tumor, finally the therapeutic decision is taken on the basis of which we plan surgery, chemotherapy, radiation therapy or transplantation. Now we come to primary malignant tumor. Primary malignant tumors, the most common is the sarcomas. Though the primary cardiac malignancy is uncommon, but among it, sarcomas are sporadic in origin and affect the adults over 40. Patient may present with congestive heart failure, pleuritic chest pain, malaise, anorexia and weight loss, refractory arrhythmias, syncope, pericardial effusion and tamponade. Complete surgical excision is indicated, and if large, then transplantation. Non-sarcomatous primary malignant cardiac tumors include lymphomas. They are rare, but they respond good to chemo and radiotherapy. And after complete or incomplete resection followed by chemo and radio, there is 3-year survival. Then the most common than the primary are the secondary metastatic tumors. Here is a pie chart showing the incidence of the various metastatic tumors. So among the metastatic tumors, carcinoma is the most common, which comprise around 55%, followed by lymphomas, then leukemias, sarcomas, melanomas, and miscellaneous. Out of these, only 10% of patients with metastatic cardiac tumors are afflicted and present with symptoms, among which most common symptom is pericardial effusion or tamponade with refractory arrhythmias or congestive heart failure. Echo is diagnostic, and surgical therapy is only done for symptomatic palliation. Here are the various organs of the body showing the incidence of the primary tumor metastasis to the heart. From oral cavity it is around 6%, tongue it is 9%, thyroid it is 21%, oronasal pharynx it is around 10%, larynx 12%, esophagus 23.5%. From lungs it is around 26, bronchi 27, from breast tissue it is around 18, liver it is 6%, gallbladder 7.6, stomach around 4, pancreas 10%, kidney 13.7. From the bladder, urinary bladder it is around 9%, and colon and rectum it is 2 to 3%. In males, from prostate it is around 3 and testis 16%, whereas in female organs from ovary it is around 6%, uterine it is 5, endometrium it is around 9.4%. So this briefly show the incidences of primary metastasis going to the heart. So the therapy for the malignant tumor basically aims at identifying the primary site of metastasis and then identifying the location of the tumor, that is pericardial, epicardial, myocardial or intracavitary. On identification of type and extent of tumor, we plan the patient for surgery, radiation, chemotherapy, cardiocentesis. Repeated or combined palliative care may be necessary. So surgical therapy in case of primary metastatic tumor, because the most common presentation is pericardial effusion or tamponade, it aims at only providing limited relief to the recurrent effusion and tamponade. Because the disease is already widespread and patient has limited life expectancies. So the aim remains at symptomatic palliation with minimal patient discomfort and hospital stay. Surgical approach can be subxiphoid pericardiotomy or by creating a large pericardial window in left pleural space via thoracoscopy. Thank you.